Good afternoon and welcome to our Oncology Lecture Series. I am Dr. Galway Hakim, Assistant Vice President of International Healthcare Partnerships and Insurance Development at Baptist Health International. It is my pleasure to welcome all of you to this informative presentation. I would like to extend warm greetings to our friends across Latin America, the Caribbean, and everyone joining us today. During this interactive presentation, you will have the ability to ask questions via the Q&A feature located at the bottom of your screen. I will be your moderator for today's lecture. This afternoon, I have the distinct pleasure of introducing Dr. Cesar Ochoa Perez. His presentation is titled Updates in the Management of Lung Cancer. Dr. Ochoa Perez is a medical oncologist at Miami Cancer Institute, which is part of Baptist Health. Dr. Ochoa Perez is a board-certified in internal medicine and medical oncology and specializes in the treatment of lung, head, and neck cancers. Dr. Ochoa Perez received his medical training at Tecnológico de Monterrey School of Medicine in Monterrey, Mexico. He completed his residency in internal medicine at Wayne State University Henry Ford Health System in Detroit, Michigan. He then completed a postdoctoral research fellowship at the University of Texas MD Anderson Cancer Center in Houston, Texas, and a hematology oncology fellowship at Mayo Clinic School of Graduate Medical Education in Jacksonville, Florida. Prior to joining Miami Cancer Institute in 2021, Dr. Ochoa Perez was on staff at the Billings Clinic Cancer Center, where he worked as a medical oncologist. Throughout his career, Dr. Ochoa Perez has been involved in research focusing on the role of intrinsic and extrinsic airway inflammation in the development and growth of lung cancer. This work has had major implications in the improvement of currently available therapies to better understand lung cancer. Dr. Ochoa Perez's research has been published in numerous peer-reviewed publications, including Cancer Research, Cancer Prevention Research, Molecular Cancer, Onco-Immunology, Expert Review of Anti-Cancer Therapy, among others. He has also presented his work at multiple national and international conferences. He's a member of the American Society of Clinical Oncology, the American Society of Hematology, the American Medical Association, and the American College of Physicians, among other professional associations. Dr. Ochoa Perez is fluent in English and Spanish, and it is a true pleasure welcome you, Dr. Ochoa Perez, to this symposium, to this conference today. Thank you so much for accepting our invitation. You may share your screen whenever you have a chance.
Okay, thank you for your kind words and the warm introduction, Dr. Hakim. Are you guys able to see my slides?
Yes, we can.
Fantastic. Okay, we're ready to start?
Yes, we are.
All right. Well, thank you everyone for joining. I'm Cesar Ochoa. As Dr. Hakim said, I'm a medical oncologist here with the Miami Cancer Institute. I focus and specialize in the treatment of lung cancers, and they asked me to give a brief talk with updates on the current management of lung cancer. So we're going to try to use the next 30-40 minutes to do our very best to cover a lot of information. So let's get started. All right. So I wanted to start with this first slide. This is a image, that is published every year by the American Cancer Society, and it gives a projected number of the estimated new cases for each cancer type. This is the publication for 2022. And as you can see, there are short of 1 million cases projected in men and women. These are new cancer cases. And at the very top of that list, you're going to find that about 1/3 of those cases are going to be breast cancer patients in women, and about 1/3 or a little bit less than that of prostate cancer in men. Shortly behind that, you're going to see that lung is around 12% of all those new estimated cases. While we are ranked number 2 in terms of incidence, unfortunately, we do rank number 1 in terms of cancer-related deaths. A lot of lung cancers tend to be diagnosed when they're at advanced stage, and the prognosis there, changes dramatically. So we got to keep that in mind, that although the incidence has been declining, there's still a lot of work to do. So like I mentioned, just a minute ago, lung cancer rates have been declining now for decades. This is probably in part because we were smoking a whole lot less as a society. There's also been significant advances in detection and screening that allow us to identify a lot of these cancers when they're small and localized, which allows us to better treat them and to provide patients with better outcomes. And with this, survival rates have been improving steadily over the past 20 years or so. And we have more and better treatment options. Almost every year, there seems to be a new advance that pushes the field forward. So over the next few minutes, I'm going to be talking a little bit about prevention, a little bit about screening, some very basic concepts in regards to diagnosis and staging, and I will give a brief treatment overview of lung cancer by treatment stage. I will try to include our current standards of care and some of the new developments and new drug approvals in the field. And we'll leave plenty of time, I hope, for questions. In the interest of staying in time, I will be talking about non-small cell lung cancer only. I will not be covering some of the less common types of lung cancer, such as small cell, mesothelioma, and others. Those will be completely different presentation. So moving on, most people know that lung cancers are going to be associated to cigarette smoking. And I think there's been a lot of emphasis by this, and pretty much everybody knows that smoking is bad. So prevention is key for not only lung cancer, but any type of cancer. So I always tell my patients that if you can do one single thing to improve your overall health, is quitting smoking. Smoking cessation is essential. It decreases the risk of not only heart disease and cancer and many other things, but it can also be associated with improved prognosis in patients who are undergoing treatment for lung cancer and other cancers. Here in the United States, we have many resources that are free and available to people who want to quit, either over the phone or online. But we need to do a better job as providers at identifying those patients of ours who are smokers, and a single 30-second intervention saying, hey, smoking is bad, what do we need to get you to quit, can make a big difference. So I encourage everybody to do that with their own patients, or not even patients, family members or friends. So other than smoking, what other risk factors are we aware of in lung cancer? Definitely smoking, and that includes not only cigarettes, but cigars, pipes, etc. The jury is still out on whether some of these vaping or e-cigarettes and electronic cigarettes, pose a risk for smoking. It's a little bit early to say, but what I can say is that smoke causes irritation to the lung lining, and this is generally not good for your lungs. It's associated to inflammation, and we know that inflammation is a cancer promoter. So if we smoke, or if we are exposed to smoke, the increased risk is there. We know from some studies that secondhand smoke, these are people or persons who live in a house where somebody smokes, can have a 20 to 30% increased risk of developing lung cancer in their lifetime. That's incredible. That's a lot. We also need to be aware of family history. Some of these cancers can be associated with familiar conditions where cancer tends to run in families. And also environment or workplace factors. Environment could be people who are working in a field where they're exposed to toxic fumes or chemicals, who work as, say, firefighters, where they might be exposed to burning of different materials, or people who are exposed to things like radiation as part of their job, or who receive treatment with radiation for certain specific conditions like breast cancer or lymphomas. We know that some of those patients can have an increased risk of the development of lung cancer that sometimes takes 20 or 30 years to manifest. So those are the main things that we need to keep in mind. Most recently, some of our European societies have kind of made it official that environmental pollution can also be playing a role in the development of lung cancer. So a slide here on screening. Screening has the goal of early detection. This is finding these cancers when they're localized, when they're really small, and when we can really do quite a lot to help those patients. We are lagging behind, significantly behind mammograms, behind colonoscopies, where everybody knows that those interventions can detect early cancers and hopefully lead to better outcomes. Not a lot of people know that there are good screening tests for lung cancer. So our national guidelines do recommend doing a low-dose CT scan every year in patients who are between the ages of 50 and 80 years old, who have a strong or a heavy smoking history. They define that as 20-pack year smoking, and that includes current smokers or people who quit in the past 15 years. We're not doing sputum samples anymore. We're not doing normal x-rays. These are standard of care as of now for screening. So what does this low-dose CT imply? What does it mean? How do we do it? Well, most of us might be familiar with the conventional CT scan. By now, we do those all the time in hospitals and in clinics. So it's really a high definition X-ray picture that allows us to take a very detailed look at the lungs. The difference between this and the conventional CT scan is that the amount of radiation that we use here is significantly lower, about a fifth of what we typically use in a conventional CT scan. And this is one intervention that allows us to identify small nodules. And I will not be covering that here today, but there's very specific criteria on how to act upon those nodules depending on the size, the location, the characteristics, and the patient's risk factors. Some of the less concerning ones can be followed with more imaging. Some of the more concerning ones, we might recommend to proceed with either a surgical resection or a biopsy. This intervention, this yearly low-dose CT scan in the high-risk patients, has shown to decrease the risk of dying from lung cancer in that specific population. So that is a big deal, and we all should be aware of this option. Are there any risks associated with screening? And I always mention this to my patients. No test is perfect. There are some risks associated with screening, so we need to be careful when we select which patients end up going for these procedures. We know that we can, in some cases, encounter false positives. This means finding something that is a benign finding, and this might lead in some cases to unnecessary invasive procedures or biopsies, which in some cases can cause problems like bleeding, infections, and others. We can sometimes get falsely reassured with false negatives. The fact that the scan doesn't identify anything doesn't guarantee me 100% that there might not be a lesion hiding in there somewhere. There can be instances where we overdiagnose some very small cancers that are otherwise slow growing and would have never really posed a risk to the patient. And there's always the concern for radiation exposure. We're very well aware of this. And like I mentioned before, the amount of radiation here, although it's more than a typical X-ray, is significantly less than a conventional CT scan. And in this particular patient population that I mentioned, heavy smokers between the ages of 50 and 80, we strongly believe that the benefits outweigh the risks. Moving forward to some of the basics of diagnosis and staging, I said that I was going to cover only non-small cell lung cancer. And non-small cell lung cancer can be subdivided in different types, and I'm including the two more common ones here, adenocarcinoma and squamous cell. So every patient that comes to me, that comes to our clinic, will have a biopsy. This can be a CT-guided biopsy or endoscopically obtained sample, and the biopsy will be sent over to our lab to run immunohistochemistry to try to differentiate between these two types of cancer. The adenocarcinoma will be positive for TTF1 and CK720, the squamous cell typically for P63. This is important because this has a lot of implications in not only prognosis, but treatment and response to therapies. So very important. Patients will also undergo a number of imaging tests, usually a PET scan, a brain MRI, in some cases others, to try to properly stage our patients. This right here is the most recent iteration of the AJCC staging system. the famous T&M staging that uses tumor size, the presence of lymph nodes, and or metastatic disease to group patients into prognostic stages that go from stage 1 to stage 4, 1 for the earliest, 4 for the most advanced. And we really rely on this to be able to offer the best treatment and the best prognostic outcomes for our patients. I will not go into detail. This is widely available online. Moving forward to a treatment overview, I'm listing here stage 1 as the earliest in lung cancer, followed by stage 2, stage 3, which is subdivided in A and B, and lastly stage 4, and kind of giving you a one-liner on how we treat these patients. Stage 1 lung cancer patients typically have a small single lesion in one of their lungs, and I usually don't get very involved in these cases because the treatment is usually surgical. We refer them to our colleagues in cardiothoracic surgery, and they might resect the involved area, or in those patients who are not good candidates for surgery or who decline surgery for whatever reason, radiation can be highly effective at curing many of these patients. Stage 2 and above is usually when the medical oncology gets a little bit more involved. Stage 2 might be a patient who has maybe a larger tumor, maybe a larger tumor with some high risk features on the specimen. And a lot of these patients will benefit from some form of adjuvant therapy, specifically chemotherapy, after their surgery. The goal of the chemotherapy being decrease the risk of recurrence and improving survival, but still with the curative intent. Then we have the stage 3 patients, which is an area of controversy in lung cancer. These cases are always complex and frequently discussed at our multidisciplinary tumor boards. The vast majority of these patients are going to be treated with a combination of chemotherapy and radiation together, followed by immunotherapy. A small percentage of these patients that are thought to be good surgical candidates might be treated with upfront chemotherapy, with or without immunotherapy, and then surgery. And lastly, our stage 4 patients are the patients who have unfortunately developed metastatic disease. They require systemic therapy, meaning a treatment modality that treats the whole body, and that would include things like chemotherapy, immunotherapy, and targeted therapy. So this first slide is a summary of the now famous LACE meta-analysis that was published back in 2008. Sounds like an eternity ago. This meta-analysis looked into the biggest studies that we had up until that point, well over 4,000 patients, trials evaluating the role of adjuvant chemotherapy, and they grouped them together. And essentially the results of this analysis was that post-operative chemotherapy with a cisplatin-based regimen significantly improved survival in these non-small cell lung cancers. The benefit was small, but significant, as seen by the curves of overall survival and disease-free survival, and limited to those patients with stages 2 and 3. So this became our standard of care back in the 2008, 2009. Post-operative chemotherapy using cisplatin together with a second chemotherapy drug. We call those platinum doublets. Despite that, many patients will ultimately develop progressive disease or the development of metastatic disease. So a lot of research was focused on trying to improve these outcomes. Another slide here from 2016 compared the different types of chemotherapy combinations: cisplatin with docetaxel, cisplatin with gemcitabine, cisplatin with pemetrexed, etc., and compare them against each other to see, which one came on top. And the study essentially said that there was no significant difference between the most common regimens of chemotherapy, either on the squamous or non-squamous histologies. Essentially, confirming what we suspected, that there's really no true difference on which type of chemotherapy we used, as long as we use that combination with a cisplatin agent. So what is new in this adjuvant setting? What has research shown? How can we improve on the results of those chemotherapy trials? Well, 2020 shed some good information here. The ADAURA trial looked into the role of a medication, an EGFR tyrosine kinase called osimertinib, as an adjuvant therapy in patients with stage 1B to stage 3A non-small cell lung cancer. So these were patients who might have received chemotherapy, the standard chemotherapy that I mentioned just a minute ago, or were not candidates for that, went on to receive adjuvant osimertinib. This is a pill, an oral medication taken once a day. And they treated these patients for 3 years. And the curves right there show a significant improvement in the disease-free survival when compared to placebo. So this has now become our standard of care for those patients who harbor an EGFR mutation. This is not going to be every single patient. It's only patients that are EGFR mutants. So as part of our practice over here, we check every single patient for molecular testing to identify these mutations. And this is wonderful, because even patients who do not complete chemotherapy for whatever reason, or who are not good candidates for chemotherapy, still see some benefit from osimertinib in the adjuvant setting. And it's a medication that is usually very, very well tolerated. Another study that improves on the role of chemotherapy is Empower 010. This was published just about 1.5 years ago. It was looking at the same patient population, stage 1B to stage 3 non-small cell lung cancer. And it looked into adding a form of immunotherapy, a checkpoint inhibitor by the name of atezolizumab, after completing that adjuvant chemotherapy. And again, I'm showing you the curves there for disease-free survival, and it showed a pronounced benefit in patients who were positive or who expressed PD-L1 receptor, which is our marker that predicts for the response to immunotherapy. This is a IV medication, an intravenous medication, an infusion that is given once every 21 days for up to 1 year. And more recently, the FDA also approved a more extended dosing where we can stretch out the amount of infusions. Another medication that is usually very well tolerated and is proven to be beneficial for our patients. I'm gonna switch to the stage 3 stage. The patients that I mentioned, that most of the cases are going to be treated by chemoradiation. So chemoradiation in these cases is typically given on a daily basis, meaning chemotherapy is administered once a week and radiation 5 days a week. And we do this for approximately 5 to 6 weeks. And at that point, we re-image, and if we see a positive response to therapy, we used to just closely surveil those patients. Again, some of these patients will unfortunately recur or have a relapse, and a lot of research has been going into how to minimize the risk of that happening. So this is a major breakthrough. The Pacific trial came out in 2017. This looked into the addition of another checkpoint inhibitor. The name of it is durvalumab, in patients who had stage 3 lung cancer, who completed the standard of care chemotherapy and radiation and had no evidence of progression at the end of their treatment. They were randomized to receive either a placebo or atezolizumab, or durvalumab. And durvalumab significantly improved survival in these patients. The graph that I'm showing you here is the most recent data on this. That was the 5-year overall survival update, and that benefit persists even 5 years after. This is a medication that is dosed IV based on weight every 2 days for up to 1 year. Another advance in this area, this is very recent from earlier this year. It also involves immunotherapy. this is the Checkmate 816 study that looked into those stage 3 lung cancer patients that are potential candidates for surgery. We would typically treat these patients with chemotherapy and then send them over to the surgeon to do a resection. So this study evaluated whether the addition of immunotherapy to this chemotherapy backbone would improve results and outcomes. And it was a positive study in the sense that it improved the combination of nivolumab, immunotherapy plus chemotherapy, improved the event-free survival and had a dramatic impact on the pathological complete response. That's the graph that you see on the bottom. Chemotherapy alone achieved a pathological complete response of about 2%, whereas the patients who received immunotherapy on top of chemo, it was 24%. We tend to believe that pathological complete response is another way of looking into survival, so a very positive result there. The nivolumab dose that was used here was 360 milligrams every 21 days for 3 cycles, given together with a platinum doublet, and then followed by a surgical resection. So this is also one of our new standards of care, and we're using this more and more. Now, moving to our stage 4 patients, where systemic therapy is the mainstay of treatment, I'll show you here this data pie chart from Memorial Sloan Kettering that shows us that non-small cell lung cancer is obviously not a single disease. I already told you that it can be an adenocarcinoma or a squamous cell carcinoma, but in reality, it might be way more complex than that. We know that there are many different subtypes of non-small cell lung cancers, and they might behave different, and we might have different treatment options for them. So this chart shows the most common ones: the GFR mutants, the KRAS mutants, the ALK, the ROS, the BRAF, the METX14s, the HER2s, the RETs, and the NTRKs. So not a single disease, many diseases with many treatments. So I'll go a little bit into how we decide which is the best treatment for whom and why. So this graph over here kind of summarizes our current approach for the first-line treatment of those patients with advanced or metastatic non-small cell lung cancer. We diagnose histologically with a biopsy, immunohistochemistry. We do that for everyone. We do molecular analysis, and we do that for most of our patients in the early setting and everyone in the advanced setting. This helps us identify any driver mutations such as EGFR, ALK, ROS, BRAF, etc. And we also do PD-L1 testing. PD-L1 is our test that helps us identify who are our candidates for immunotherapies. With all this information, we can divide patients into targeted therapy for those who have a driver mutation. For those who do not have a driver mutation, PD-L1 testing is crucial because those with the high PD-L1 level can actually avoid chemotherapy and be treated with a single agent immunotherapy drug. And those patients who do not have driver mutations and have a low PD-L1 score, in which chemotherapy still plays a significant role, but the addition of immunotherapy can significantly improve outcomes. Like I said, many diseases, many treatments. This is a summary of the first-line treatment options for metastatic lung cancer with a driver mutation. So this list seems to be getting bigger and bigger every year. When I was a resident, we only had a few of these, and every year this list gets bigger and bigger. That's a good problem to have, I think. We have many options for EGFR. Osimertinib is my preferred and one of the preferred first lines in general. ALK fusions, we typically treat with alectinib. BRAF, B600E, this is a mutation that is very common in melanomas, but we've also identified it in a subset of lung cancer. We have a couple of inhibitors that are actually quite successful at treating this. ROS and NTRK fusions, we have medications for that, and some of the less common mutations such as RET and MET recently had FDA approvals that just a few years ago we were not even imagining. So what is new in targeted therapies? I told you this list is getting bigger every year. These are new approvals from just 2022. So more targeted therapies that target those specific gene changes or gene mutations to slow down tumor growth and improve our survivals. Tepotinib was approved earlier this year for exon 14 MET mutations. 2 drugs for a EGFR exon 20 insertion, 1 IV, 1 oral, and 1 medication, the first medication that targets KRAS, which is one of the most common ones. And for many, many years, we did not have a good drug for this. So sotorasib is now approved by the FDA, and more data will come on that in the upcoming years in terms of the long-term survival that we can see here. Going on to the patients with no driver mutations, those patients that have a high PD-L1 score and 50% is our cutoff, can be treated with immunotherapy alone. And the slide that I'm showing you here is the Keynote-024 trial from 2016, which compared patients with metastatic lung cancer in a PD-L1 expression of 50% or higher to receive either the standard of care at the time, which is chemotherapy, versus chemotherapy plus immunotherapy, specifically pembrolizumab. And this resulted not only in a significant progression-free survival and overall survival, as seen in the graph right here, but also in significant fewer side effects compared with chemotherapy. So a fantastic positive study that is our new standard of care. So what is new in the immuno-oncology world with these immunotherapies that we can add to chemotherapy? Well, pembrolizumab was probably the first one that became a big deal. Since then, we have had approvals for atezolizumab, the combination of nivolumab and ipilimumab, as well as others. And from this year, cemiplimab, a drug that we know from skin cancer, has now made its way to lung cancer as well. Has been approved in patients with advanced non-small cell lung cancer with a high PD-L1 expression. And this is better compared to chemotherapy. I wanted to include this slide in here because we've been talking about immunotherapy for a few slides right now. And I wanted to kind of mention a little bit about the differences between this and conventional chemotherapy. There are 2 different type of medications that we sometimes use together, but they work in very different fashion. Conventional chemotherapy or cytotoxic chemotherapy are essentially medications that are toxic to cancer cells, but can also be toxic to some of our normal cells. And they're responsible for a lot of the side effects that we all hear about, like hair loss, mouth sores, nausea, vomiting, etc. Immunotherapy works different from that. It's a medication that allows our own immune system to do the work of fighting cancer by inhibiting the PD-L1 or the CTLA-4 checkpoints, therefore kind of releasing the brakes on the immune system. So the side effects that we see here tend to be quite different. They tend to be inflammation, and this inflammation can manifest essentially anywhere in the body. This is a big list, and in my clinical practice, I do see quite a few of these side effects, particularly rash, particularly elevation of liver function tests, maybe some issues with pneumonitis or colitis, thyroiditis. For the most part, a lot of these symptoms can be easy to manage, either by holding or delaying treatment for a few days or a few weeks, or by reversing them with the use of steroids. But some of those, such as colitis or pneumonitis, can be significant. And when they are, we need to figure out an alternative to using immunotherapy, because rechallenging can be dangerous in those scenarios, but a completely different side effect profile. Okay, now moving to our metastatic patients with no driver mutations and a low PD-L1 score. Here, the mainstay of therapy is still going to be chemotherapy, but with the incorporation of immunotherapy. There's a number of combinations that have showed an improved progression-free survival and overall survival in this setting when compared to chemotherapy alone. The different combinations are specific to tumor histology and tumor type. You're going to find certain combinations that are better for squamous and some better for non-squamous etiologies. And this is a partial list. These combinations also seem to be more and more every year. I'm going to show you probably the initial one from back in 2018, Keynote 189, a study that enrolled patients with metastatic non-squamous non-small cell lung cancer that had no driver mutations. And this study added pembrolizumab, a checkpoint inhibitor, to the standard chemotherapy regimen and compare that versus chemotherapy with a placebo, and this significantly improved overall survival as well as PFS. So this is our new standard of care here for the non-squamous etiologies. And the counterpart for that is Keynote 407, which did the exact same approach, but for patients with squamous histology. And again, we saw an improvement in overall survival and progression-free survival when compared to chemotherapy alone. This slide right here tries to summarize the last 25 or 30 years of advances in lung cancers in a single slide. And as you can see, over the past 5 or 6 years, the slide becomes a little busier. This means that there's been a significant increase in the number of available therapies, both targeted therapies, immunotherapies, and chemotherapy combinations that will continue to improve the outcomes of our patients. So this is only going to get more and more crowded, hopefully. So what are my take-home points from this brief presentation? Well, more people in the United States are dying from lung cancer than from any other type of cancer. So although our incidents are coming down, we're smoking less, we're detecting things earlier, there's still a lot of work to be done. So screening, very important, as this can lead to an early diagnosis and obviously a better outcome. Prevention, specifically smoking cessation, is paramount. And more and better treatment options are now available compared to just a couple of years ago, and more to come. And that long-term survival is possible even in patients with advanced disease. Before the era of immunotherapies, we used to think that most patients with advanced lung cancer would live on average 1 year, maybe even less. After the advent of all these immunotherapies, we have patients living 2, 3, 4, 5 years. I showed you a slide that was looking at survival at 5 years. So the outcomes have significantly improved. There's much to be done, but we're heading in the right direction. Thank you so much, Dr. Hakim.
Thank you so very much, Dr. Ochoa Perez. What a great summary and a phenomenal presentation. You closed with a very to the point, kind of difficult to swallow type information, being lung cancer at 12% of the total estimated cases that you mentioned initially, and being the #1 responsible for cancer death. So that is perhaps one of the most alarming things that we still have. You're absolutely right. The campaigns that we have endured in the past 10 years in regards to cancer awareness and the smoking cessation and all these activities have definitely assisted and helped our communities to see a decrease in the incidence of cancer, but still it is one of those that are mind-boggling for many. So I wanted to just point out at one of the exciting immunotherapies that you mentioned, and that has been part of the talks in many circles, and it has to do with the Checkmate 816. The nivolumab perhaps was one of the first FDA-approved immunotherapies that we see in use, which is very exciting. And I love the fact that you mentioned that in combination with the traditional chemotherapy, it is perhaps giving great results. What is your personal experience in treating and using this particular type of immunotherapy with the traditional chemotherapies that you're accustomed to using?
Yeah, no, my experience has been incredibly positive. You know, I did my training. I started my training as an oncologist right at the time when all these exciting data was coming. You know, it sounds like many years ago, but it was not that long ago.
Mm.
And we went very quickly from seeing patients, you know, really not do very well, specifically lung cancer patients or melanoma patients, where a lot of this initial research, you know, comes from, drastically changing their prognosis. Some of the initial medications that were approved, one of them was ipilimumab. It's a different type of checkpoint inhibitor. Was then followed by nivolumab and pembrolizumab, and now we have a big list. Were first used, obviously, in the metastatic setting, the most advanced disease. And as of 2018, for those patients who have a high likelihood of responding to an immune therapy, that became the standard of care alone, beating chemotherapy, better outcomes, better survival, and more importantly, less side effects and less quality of life.
Mhm.
It's unfortunately not seen across the board. You know, that great benefit is usually seen in those patients who have a high PD-L1 score. Those are the patients that extract the most benefit. But as I mentioned in my slides, even those patients who do not have a low PD-L1 score, who will still receive chemotherapy, can get additional benefit from the addition of one of these immune checkpoint inhibitors.
Mhm.
And in my experience, you know, the quality of life is significantly better. Chemotherapy versus immunotherapy. You're not going to lose your hair. You're not going to get bad nausea and vomiting. All those symptoms are usually not there. There are medications that they still do some side effects, and some of them can be serious, as I show in one of my slides. But in my experience, we're able to successfully manage a lot of those with interventions such as steroids and immune modulators.
Mhm. You did mention briefly also that we don't have necessarily data that correlates with the use of those pipes, what do you call it? The cigarette substitutes.
Vaping and e-cigarettes.
Yeah, and there are multiple schools of thoughts, obviously, and not too long ago, the one of the main companies decided to cease operations or not continue to distribute those kind of substances. In your personal opinion as an oncologist, do you see any correlation between the vaping new environment, the new individuals that are vaping, and something that we will see in the future, perhaps? In lung cancer?
It's hard to say at this point. You know, all these e-cigarettes and all these vaping really came only a few years ago. So we don't really have a lot of mature data like we have for cigarette smoking, which we have studies dating, you know, 40 years. So we have very, very compelling data there. Here, the jury's still out in the sense that we don't have a good study that, you know, proves or disproves. My approach to that is like I mentioned in my slides. Smoke itself, not doesn't have to be the nicotine or a cigarette or a pipe. Smoke itself can be an irritant to the airway, and that itself can trigger a number of problems. You know, from obstructive disease to pulmonary inflammation. And we know that pulmonary inflammation is a big risk factor for lung cancer. Part of my research when I was a postdoc some years ago actually looked into this. You know, we were studying animals, rats, and all those kinds of things, and we were trying to elicit, you know, lung inflammation to see how much of an effect did that have on cancer. So we'd expose animals, you know, to a smoke chamber, right? And it was not a cigarette; it was just really smoke. So all this smoke exposure would trigger inflammation, and it actually accelerated cancer growth. We don't have those studies in humans, but my opinion is that smoke, the irritation, the mechanical irritation from it, whether it's from pollution or from a fume or from smoking or from vaping, it's not good for your lungs. Whether that will correlate with cancer incidence in the future, too early to say.
Mhm. The other kind of group of individuals that come to us, especially internationally, that perhaps come a little bit late in their staging, is those that already have metastatic lung cancer, and they're trying to seek something to treat them. We know how aggressive cancer, especially in the lungs, could be, especially because of the statistics you provided. Do you see any light at the end of the tunnel, especially for stage 3 and 4 lung cancer that are metastasized due to other primary tumors?
No, definitely, definitely. So I think something that we do, and we do very well here at Miami Cancer Institute, is for a lot of these metastatic patients, we obtain not only the slides for review and confirming the diagnosis, but we also send for molecular testing, meaning try to identify the molecular makeup of this tumor. So is there any driver mutation or a targetable mutation that would allow us to treat some of these patients with an oral targeted therapy and avoid chemotherapy altogether, to allow them to enroll in clinical trials, or in those patients that have high PD-L1 markers, get them started on some form of immunotherapy, which also avoids altogether, chemotherapy. And in my experience, some of these patients with high PD-L1 scores who go on to receive single agent immunotherapy, whether it's nivolumab, pembrolizumab, atezolizumab, or one of the newer ones, and there's more checkpoint inhibitors coming very soon. Not everybody responds the way that we would hope for, but those patients who do respond can have dramatic responses, which can be long-term. Every year at our national meetings, we get the update, like the 4-year update, the 5-year update. And we're talking about 5-year updates when I just told you that we used to think that the prognosis was 1 year. Mm-hmm. So although there's a lot of work to do, that's, I think, a huge success that we're going to continue to build upon.
We agree. There are obviously great clinical trials that we have at Miami Cancer Institute, and of course in the areas that you practice as well. One of which I don't recall exactly the name of the clinical trial, led by Dr. Rupesh Kotesha in radio oncology, that combines both chemotherapy and a device to be used as radiation emitting type device on the lungs as patches. I don't know if you know or what I'm talking about, or which clinical trial. I'm sorry, I cannot think of it now, but it seems also very promising that we think in ways of actually using the home environment of the patient to continue this type of therapies, comfortably receiving those emissions for radiotherapy as well as chemotherapy when needed, but in their own environment. So that in your opinion, what that constitutes to you?
Yeah, no, lots of advances and lots of clinical trials, right, that are looking into improving upon some of our current standards. That's, I think, the way to progress. You find something that works, you use it, but how do you improve upon that? Can you add another medication or another device or a form of radiation or another intervention that improves your outcome there? Or alternatively, how you make it easier on the patient, in the sense, how do you minimize side effects, toxicities, and in other words, improving quality of life? When we talk about these patients with very advanced lung cancer, unfortunately, we're not able to offer many of them a cure, but we're always able to offer an improvement in the quality of life. And I think a lot of the clinical trials in the metastatic setting are aiming at finding the right combinations of the right medications that would allow us, that long-term benefit while minimizing toxicities and improving quality of life.
We're very hopeful, especially for your type of specialty, to actually hear you say in the future it has decreased dramatically, similarly to what happened with breast cancer and the data that we just received, that it has definitely worked and has decreased the incidence of breast cancer, and the treatment actually has been very receptive and responsive. So hopefully for your area in lung, you'll be able to share that with us. One more question from Dr. Fermin, and he's asking or wondering, is there any correlation that you know of in regards to cancer that is related to sequelas of COVID-19?
Very, very, very good question. I think it's early to know that. COVID-19 has changed a lot, in all of our lives. And during the, worst times of the pandemic, when we were dealing with full hospitals and all those kinds of things a year or two ago, we learned that there were a lot of complications from it that we were not expecting. Things like increased development of blood clots and other kind of unusual effects, and we're learning to recognize more of those effects, the long COVID syndrome and all those kinds of things. So I think it's, to my knowledge, I'm not aware of any direct implications in there. But again, very early to say, this is only a year or two away, right?
Surprises will come probably, hopefully not as dramatic as a cancer due to this kind of disease. Dr. Ochoa, Perez, we can keep you for a long time if you allow us, but we need to be considerate to you. What a wonderful presentation. You're a phenomenal speaker. Thank you so very much. And on behalf of our entire team at Baptist Health International, thank you for this incredibly informative presentation, and to all of you for participating and for attending today's conference. If you have additional questions about today's presentation for Dr. Ochoa Perez, please feel free to email them at BHIWebinars@baptisthealth.net. That's BHIWebinars@baptisthealth.net. We'll make sure to forward those to him in order for him to elaborate and send it back to you. We look forward to seeing you at our next oncology lecture series scheduled on January 11th, 2023. Thank you again. Have a wonderful and great afternoon. Thank you, Dr. Ochoa Perez.
Thank you, Dr. Hakim. Thank you, everyone. Have a wonderful evening.
Thank you. You too.